Good evening to everyone present here with us today. This is Shreyan from IGCP. I would like to welcome all the viewers who have joined our platform for better exchange of knowledge that is going to be shared by our keynote speaker doctor for today's session. With much pleasure and honor, I would like to welcome a very renowned doctor, Dr. Dinesh Kullar. Sir is MBBS MD DM Nephrology, Chairman, Department of Nephrology and Renal Transplant Medicine, Max Super Specialty Hospital, Saket. With the help of Sir and his wonderful insight, we will be taking a close look on today's topic, which is slowing down CKD progression. Now, without any further delay, I would like to welcome Sir at our forum and would like to hand over the session to him. Over to you, Sir.
Well, thank you very much. At the outset, my sincere thanks to IGCP for this wonderful opportunity. I have been asked to talk about and give my perspective about how does a nephrologist in 2023 view slowing down the rate of CKD progression. And we have been fortunate that whereas we had nothing to really much to offer to our patients till about, I would just say, a decade ago, we have optimism and we have certainly been made available some new weapons which are there in our armamentarium, and they have played a very stellar role in the way we look at managing these patients. So it's quite encouraging to see the availability of a few of these weapons. Well, before we begin, it's extremely important to understand the magnitude of problem. And I think if we look at our own country, forget about where the whole world is heading towards as far as the incidence and prevalence of chronic kidney disease is concerned, if we believe that about anywhere between 10 to 15% of Indian population has some form of chronic kidney disease. Look at the numbers. 140 crore of Indian population, out of which about 10% at least have some kind of chronic kidney disease. On the other hand, if you look at the number of diabetics, anywhere, let's not go into the exactness of the numbers, but then if we believe, and I'm sure everyone would agree to it, good about 9 to 10 crore of Indian population is probably suffering from diabetes. And if we were to understand that good about 40%, anywhere between 33% to 67% will have renal involvement. If we take the number as 40% for discussion's sake, look at the numbers. 40% of 10 crore. So we are looking at a huge number of diabetic population which has chronic kidney disease. And we all know it is a progressive disease and eventually it will lead on to more and more advanced chronic kidney disease. That's one side of the story. On one hand, we are fearing the progression of chronic kidney disease, ultimately leading on to end-stage kidney disease. But the matters get compounded by the fact that not too many people actually reach the stage of end-stage kidney disease. They succumb to cardiovascular disease in between. So, yes, on one hand, we are okay that there is not too many requirement of dialysis in this population, but then we are obviously not able to save these patients beyond a certain period of time. So with that in background, let's recapitulate our knowledge of chronic kidney disease. We all know that CKD is now currently defined as anything wrong with the kidney, be it the structure or the function of them, which has been there for more than 3 months, and more importantly, with implications for health. And for that, I think, broadly speaking, we keep two things in mind. One is the albumin excretion, and the other is GFR. And we have to give due and equal importance to all these factors, which I have shown on my slide here. This is a heat map which tells us that, well, you see, if your patient has a GFR of over 90 and does not have an albuminuria, he or she is comfortably placed, as you can see in the green here. But as the GFR declines, or the albuminuria increases, look at what happens to the gravity of the situation. And eventually, these patients are ultimately going to land up with an end-stage kidney disease, the GFR of less than 15. Well, the clinical manifestations of chronic kidney disease, we all are familiar with. Again, to briefly recapitulate, we'll have to understand what the kidneys are supposed to be doing in our body. And obviously, when things go wrong, each and every aspect, be it the electrolyte the balance, the elimination of nitrogenous waste products, the erythropoietin production, the acid-base balance, the vitamin D, and the phosphate excretion, everything takes a hit, and there's a cascade of events which ultimately leads on to comorbidities, especially, as I said earlier, in the form of cardiovascular disease. And as the chronic kidney disease progresses, of course, there is a higher incidence of atherosclerotic cardiovascular disease. But what is even more problematic is the typical association of worsening chronic kidney disease with heart failure and cardiac arrhythmias. And from out of heart failure also, at times it may not be easily perceptible because they may actually be having heart failure with preserved ejection fraction. And your unless you dig deeper into what the echo findings are showing us, you may actually miss the coexistence of heart failure with preserved ejection fraction. So here are the risk factors. Before we move on to how to mitigate the CKD progression, let's try and see what are the risk factors which typically are going to cause or are going to have a bad news for our given patient with chronic kidney disease. The lifestyle habits, the of course, they fell into the trap of chronic kidney disease, quite significantly attributable to poor lifestyles. Then this is going to perpetuate. But then there are inherent problems which may not have anything to with the to do with the mistakes which our patients may have done as far as controlling their disease in the initial stages is concerned. And by that I mean the genetic predisposition. And nowadays we are learning more and more about how does the genetics influence the chronic kidney disease progression, and we can have a check over these via various biomarkers. They are still in the initial stages. NGAL has been there available to us for almost like a couple of decades now, but then it has not really reached a stage where it's of practical significance to us, and we have nothing beyond serum creatinine, really speaking, to be able to reflect on the given patient's kidney function. But that does not mean that creatinine is not a great marker. It has its fallacies, but all said and done, it is the best thing which gives us the which reflects on the patient's kidney function, and via the extrapolated information which we get from GFR when we extrapolate the value of serum creatinine. And of course, you have the various reasons as to why the kidney failure happened, and that may have a bearing on the kind of progression which we have, because there are few kidney diseases which progress much faster, especially like diabetes or diabetic kidney disease, or patients with chronic glomerular disease with very heavy proteinuria tend to progress at a much faster rate. And this is the complications, and this is a vicious cycle whereby kidney disease causes anemia, and anemia in turn may actually aggravate the chronic kidney disease. Similarly, metabolic acidosis may be the result of chronic kidney disease, but eventually you find metabolic acidosis also playing a part in the progression of chronic kidney disease, and we'll come back to that a little later. And then ultimately, you see, as I said earlier, there is a coexistence. It's not just the kidney disease; it is basically the interaction between various organ systems, the interaction typically which multisystemic disorders like hypertension, diabetes, and autoimmune diseases can actually have it. And of course, where we have to be very vigilant and mindful of the fact that there are many drugs and toxins which probably could actually be administered to a given patient with chronic kidney disease inadvertently, which should have actually been avoided. But it's our earnest responsibility to make sure that we do not allow that to happen. And then, of course, there are non-modifiable factors such as socioeconomic and the gender of the patient. So let's now, with this background, try to see how can we attempt slowing down the rate of progression. Because by definition, chronic kidney disease means it's a progressive disease, it's an irreversible disease. So the progression can only be slowed down. It can actually probably not be reversed at this stage in time. So traditionally, the strategies available to us so far have been the optimism and the faith which we can have in RAS blockade. And I think at times I must confess that our usage of RAS blockers is suboptimal. We This is a request to repose your faith in RAS blockade as much as possible, because this is one class of agents which has clearly been showing us over the years its efficacy in as far as the kidney disease is concerned, as far as the heart disease is concerned. And rather than talking about the worsening of GFR, which they may induce initially, or the risk of hyperkalemia, well, they are there. I'm not denying that they're not there, but that should not be the reason why we should refrain from using this very impressive class of drugs. Well, of course, it's not just about RAS blockade controlling your patient's blood pressure or proteinuria. Blood pressure control with whatever means is should be our first priority, and we should try and have their blood pressure to less than 130 and 80 if there is a significant proteinuria, but definitely less than 140/90 even if there is no proteinuria. We'll come back to that. There's another role of dietary protein restriction, and I would certainly like to caution at this stage only that while we are always trying to reduce the protein intake in these patients, the caution is that we have predominantly vegetarians in our country. Even those non-vegetarians, the protein intake may actually be suboptimal. So to reducing it any further may actually be detrimental to the patient's overall health. And then, of course, we have to devise strategies how to best control their diabetes, their lipids, their anemia, and of course, make sure that they do not take too much of salt. Smoking cessation, weight control is of utmost importance. And as I said earlier, it is our moral responsibility to ensure that our patients of chronic kidney disease are not given any nephrotoxic agent. Well, this is sacrosanct to all of us. Lifestyle interventions, not just when we are talking chronic kidney disease, but for that matter, all the major diseases, the lifestyle disorders which were coming across. So I think let's move on. This is something which I am quite sure is well recognized by everyone who has joined us today. Now, before I proceed, we are today wanting to know about the ways to reduce the CKD progression. And while we are looking at the GFR of these patients, trying to figure out whether we indeed have been successful or not, it is equally important to look at the albuminuria. The albuminuria, as you can see here, any reduction from one category, A3 is, as you know, is the extreme category, whereby, again, for the sake of recapitulation, the normal albumin excretion is less than 10. Between 10 and 30 is high normal. So even 10 to 30 should be taken with a pinch of salt because it is high normal. A2 is when it is between 30 and 300, and A3 is the most severe variety where the albuminuria has crossed 300. Now, if you devise any strategies which can bring back, there were times when we thought that, okay, once they have reached overt nephropathy, which we used to call them, or overt proteinuria of more than 300 milligrams, albuminuria rather, we thought that probably is going to be reversible. Not that state may not be correct any longer in 2023, where we have few agents which can actually reverse it back. So with this, as you can see here, when you are causing a more than 30% reduction, achieving more than 30% reduction in albuminuria, it actually means a lot as far as the CKD progression is concerned. From severe, they come to the category of moderate, and subsequently you can even attempt bringing it down further to the A1 stage. Now, what do the various guidelines have to tell us so far? As far as the KD go, which are very sacrosanct to us nephrologists, 2012, they gave us the goal of the blood pressure, and they talked about, as I said earlier, a BP control of less than 140/90, definitely for sure. And if there is a significant albuminuria, we should try to keep it less than 130 and 80, and we should have our faith in RAS inhibition, and there are guidelines which I'm sure are clear to everyone, the kind of glycemic control which should be achieved. And there were various other guidelines, including both from the diabetic associations or from the heart association, which talked about, which guided us the way forward. That has been known to all of us all these years. And also the fact that we should avoid nephrotoxic agents. And then we must remember that there are few key areas. If your patient has diabetic kidney disease, is old, has multiple myeloma, sepsis, underlying vascular disease, a volume depleted patient, coexisting heart failure, is a patient of organ transplantation, especially kidney transplant, and has history of exposure to multiple nephrotoxins. These are predisposed to have aggravation of their chronic kidney disease via drug-induced nephrotoxicity. And this is a list for all of us to remember that these are the kind of agents, starting from NSAIDs to amphotericin to diuretics to allopurinol to fluoroquinolones, etc., etc. We must always remember which drugs are nephrotoxic, and on the other hand, which are the drugs which require dose modification in the presence of chronic kidney disease. So both are equally important. Drugs causing nephrotoxicity and kidney disease requiring dose modification of drugs which otherwise may not have been nephrotoxic. I'm talking about drugs like acyclovir, the commonly made mistake whereby if you prescribe allopurinol to a patient, acyclovir to a patient with herpes zoster, disregarding the fact that this patient had a very advanced CKD, we can land up your patient in problems. Similarly, drugs like levosulpiride may appear quite innocuous, but not in a patient with chronic kidney disease, even trimetazidine, so many other drugs. But our collective moral responsibility to ensure that we do not administer any nephrotoxic drug as long as it's avoidable. The blood pressure control first. We have talked about that. Let's skip this and talk about glycemic control, and let's try to take into consideration the our responsibility again to a large population of diabetics in our country who have very high chances of having chronic kidney disease. Now, these are the new guidelines which say that, okay, considering the few factors, you will want to keep your patient's HbA1c in the left-sided range of less than 6.5. Now, less than 6.5, if your patient has early stages of chronic kidney disease, is a younger patient who is destined to live longer, has a higher life expectancy. There are no macrovascular complications. The patient is aware of hypoglycemia, and there is a help available to a given patient. So these are whereby you would want, and where you know that you will be able to avoid hypoglycemia in your patients. You may even want to keep to achieve an HbA1c of as low as less than 6.5%. While on the other hand, if you believe your patient is already in the higher stages of CKD, is elderly, there is no help going to be available, there are significant complications. Here, you may actually be happy by keeping the HbA1c level just less than 8, rather than trying to achieve any very stringent control of diabetes, which may actually be counterproductive, causing hypoglycemia. Well, what are the newer weapons we have been talking about, and how does it give us so much of hope, as I said, in 2023? Now, these are the various trials, very landmark trials, starting from what Credence told us. The results were published in 2019 at Melbourne World Congress of Nephrology, which showed that canagliflozin was a great weapon to be used even in patients with more advanced chronic kidney disease. Now, typically these patients were all diabetics with Credence, and we had enrolled, and we were part of this trial, landmark trial as well. This, which was prematurely stopped because of overwhelming superiority of the study drug as compared to the placebo. So they stopped it prematurely to give benefit of the drug to the other people in the placebo arm as well. The GFR, as I said, was as low as 30, and the proteinuria, the albuminuria, was between 300 milligrams to 5 grams, and they could demonstrate a significant improvement in the primary composite endpoint, which was renal. No non-diabetics were included in this trial. Subsequently, we had DAPA CKD and AMPA kidney disease. Now, mind you, these were the trials which were as an afterthought, because SGLT2 inhibitors, you all know, have been a game changer. But initially, even though everyone realized that they work via the kidneys, but then there were not many takers for SGLT2 inhibition in patients with more advanced chronic kidney disease. So it was only with credence onwards that we have data which because we have now included patients even with more advanced chronic kidney disease. So first it was 30 ml with credence of GFR, came down to 25 with the DAPA CKD, and then we went as low as AMPA kidney, as low as 20 mils per minute with AMPA kidney. And now these are the patients who, even in DAPA CKD and AMPA kidney, we included even non-diabetic patients, trying to see what SGLT2 inhibitors can do to non-diabetics as well. Very impressive results. And then, of course, we have data come up from mineralocorticoid receptor antagonists, the finerenone, again a game changer. And finally, we have seen excellent results with the semaglutide. So we'll come back to all these great molecules one by one. Talking first about SGLT2 inhibitors, what we have to understand is that in diabetics, there is upregulation of sodium and glucose transporter, as you can see from the glomerulus. From the glomerulus, once the things get the glucose and the sodium gets filtered into the proximal tubules here, there is upregulation of this transporter, and more goes back into the bloodstream, and hardly any reaches the macula densa. Now, macula densa perceives it as if nothing is reaching it. It perceives the dearth of both glucose and sodium, and it sends a signal back to the afferent arteriole that I'm not getting any supply. Please open up the gates. And what happens is the afferent arteriole opens up, and there is more of blood flowing into the glomerulus, causing intraglomerular hypertension. Now, this was trying to offset the lack of availability of sodium and glucose at the level of macula densa. But the problem is these receptors, the upregulation persists, and still there is nothing which is reaching the macula densa. So this is a perpetuation of a given cycle. Now, what can be achieved via? Now, this is going to cause an abnormally high GFR because of the intraglomerular hypertension, which will ultimately be detrimental to the kidney function, and finally they will lose this kidney function. Now, what can we do with not just empagliflozin, but then any other SGLT2 inhibitor as well? Here you can see the afferent arteriole is dilated. Now, AMPA, or for that matter, any SGLT2 inhibitor, will block this transporter, and now more and more will reach macula densa. Macula densa will send a signal back that enough is enough. Please shut the gates, and there is a restoration of the abnormally elevated GFR, and the intraglomerular hypertension goes low. So this is just the basic cartoon trying to explain how do SGLT2 inhibitors work. But we all know this is not the only way they work. They work via all these ways which I've shown here. One, of course, is they take care of the intravascular volume. But what is equally important is, as you can see here, once the kidneys do not have to be bothered too much about reabsorbing the sodium and glucose, there is less of energy expenditure, and they would rather spend this kind of energy in producing hemoglobin. So there is a restoration of erythropoietin. There is a restoration. This is like putting life back into the fibroblasts, the neural crest derived fibroblasts at the tubular levels, which account for erythropoietin production in our patients. So there is a restoration of erythropoiesis. We've already talked about tubuloglomerular feedback as to how it reduces the intraglomerular pressure, but it also has takes care of the pro-inflammatory signaling, so that there is a reduced inflammation. Of course, you can expect some improvement in the blood pressure of these patients. There is, of course, like they say, ispat bhi hum banate hain. They were originally built to be anti-diabetic drugs, so obviously they are taking care of diabetes as well. But when we are looking at cardio or the renal protection, we are looking beyond their ability to control diabetes. And of course, they take care of uric acid as well. They reduce arterial stiffness, a whole lot of functions. And that's why we have been so excited about the availability of SGLT2 inhibitors. And every day we come across some novel way by which they help our patients. Talking first about DAPA, I had briefly touched upon Credence, which was a game changer. But now DAPA CKD, because it has been shown very efficacious, not just in diabetics, but then in non-diabetics as well. Over 4,000 patients, and here, as you can see, the key inclusion area was the presence of albuminuria in a patient with GFR between 25 to 75. So from Credence 30, we have come down to 25. And the most important thing is all these patients are already on maximally tolerated dose of RAS blockers. So which is the basic prerequisite. You will always want to keep all your patients on the maximally tolerated dose of RAS blockers. On top of that, they were also non-diabetic patients, as I said. So let's move on and try to see what the results showed us. The primary composite endpoint was the renal outcomes, the sustained reduction in the GFR, or attainment of end-stage kidney disease or renal or cardiovascular death. Look at the impressive figures. Something which we came across via AMPA-REC initially, which was a cardiovascular outcome trial, and then the Canvas program, which was with Credence, another cardiovascular outcome trial, and the Declare TIMI. So these were the landmark cardiovascular outcome trials, where the post-hoc analysis told us that they are good for the heart, but probably they're even better for the kidneys. Here again, in a patient who already has a significant decline in the renal function, DAPA CKD, and I'm proud to declare that this trial is very close to my heart, being the national lead investigator for this in our country. The DAPA had shown almost close to 40% relative risk reduction in the primary composite endpoint. So very impressive data. And even in the secondary endpoints, as you can see here, there was a 44% risk reduction. Now, this is something very interesting. You can always expect some initial decline, as you can see in the blue line. This is when you had given dapagliflozin to a given patient. The initial decline, and it stabilizes. And look at what happens at the end of 1 year, at the end of 12 weeks, sorry. So this is 12 months rather, sorry. So as you can see here, the lines cross here, and then subsequently, your patient is better off if he or she was put on dapagliflozin as compared to just the standard of care. So what it means, Joe, is that you should not be overly worried about the initial decline, which is just a physiological dip, as one can see in even after when you have initiated RAS therapy, RAS inhibition therapy in your patients. To summarize, 39% relative risk reduction in the primary composite endpoint, the 44% in the renal, 29% in the cardiovascular, and 31% risk reduction in the all-cause mortality. So it was a game changer. And we wanted to see if other SGLT2 inhibitors were faring similarly. Well, AMPA kidney lowered the bar even further. It included patients with GFR as low as 20 ml. So we don't know how low can we really go, because we thought they are not going to work at GFR of less than 60. It worked. Less than 45, we were skeptical. It again worked. Credence showed us that it works at 30. DAPA CKD showed us 25, and AMPA kidney has been a positive trial again, which had to be prematurely stopped. like credence, like DAPA-CKD, even AMPA kidney was prematurely terminated because of the overwhelming superiority as compared to the standard of care in the placebo arm. So this included even more number of patients, 6,600, and here there was a small subset where there was no albuminuria as well. As you can see here, the population was CKD at risk of progression. With or without diabetes, again, there were sizable number who were not diabetic, and there was for the first time patients even who did not have an albuminuria, and this, as I showed, it is told you, got stopped last year. But what it showed was 28% risk reduction. The hazard ratio was 0.72 when you had given AMPA kidney as far as the primary composite endpoint is concerned. And similarly, as you can see, kidney progression in diabetes, 45% risk reduction, disease progression 44% when you compare it with the placebo arm, and as you can see, 41% risk reduction in diabetics with kidney disease. That means diabetic kidney disease. Well, there was a reduction in all-cause hospitalization to the tune of 14%. So these, by way of via these landmark trials, the KDIGO guidelines now recommend, in that this was as recent as 2022, their take on SGLT2 inhibitor is that they have shown to be of tremendous value in protecting your patient's kidneys and the heart. And if the patients are already being treated with other glucose lowering agents, SGLT2 inhibitor can be certainly added. And the choice should take into consideration the patient's GFR. And it is of course, you will have to master the art of prescribing SGLT2 inhibitors. This is our moral responsibility. And then, of course, we need to know as to when not to prescribe. There are sick day leaves rules when you probably may not want to, where you may want to temporarily hold this class of drugs. And as far as safety is concerned, because we always try to associate SGLT2 inhibitors with the enhanced chances of infections, the UTIs, the genital infections. Of course, they are there, but they are not bad enough to hold you back. And then all those fears of four-near gangrenes, amputations, and ketoacidosis are all gone. No one really talks about them. This is what we have learned by way of these landmark trials, as well as our real-world evidence as well. So, as I said earlier, you may find your patients experiencing transient reduction in the GFR, and one should not really be discouraged by that, and of course continue with it. And it's reasonable to continue till the GFR is as low as below 20. But I'll tell you, and I must confess, we have used it even when the GFR is lower than that as well. And even in DAPA-CKD, when the patients were allowed to be continued on dapagliflozin, even when they had reached the stage of dialysis, numerically they could demonstrate, although numbers were very small, numerically they showed a superiority when it came to cardiovascular mortality in these patients. So I think, no, I don't know how it works at ridiculously low GFRs, but they do seem to work via their direct effects on the heart. Well, let's move on. We've talked about SGLT2 inhibitors. The other very impressive class which has been made available to us recently is mineralocorticoid receptor antagonists. Now, we had our faith in the conventional mineralocorticoid receptor antagonists like aldactone and spironolactone and eplerenone. But the problem with them was that by the turn of the century, we had got a little scared using spironolactone in our patients with more advanced chronic kidney disease, because the Rails trial had shown that there are going to be high chances of hyperkalemia. But now, recently, we have come across a novel mineralocorticoid receptor antagonist, which is non-steroidal and has probably been able to eliminate the fallacies of the previously available MRAs. Now, This slide is very important. On the left-hand panel, as you can see, our first way of slowing down the rate of progression in chronic kidney disease was via RAS blockers. As you can see, the renal trial or the IDNT trial with losartan or irbesartan showed us, or the RAIN trial with ramipril showed that they were very impressive, but then they were still, as you can see here, a residual risk even after you have used, and shown that there is an improvement when you have used losartan from the top line with placebo to the green line with losartan. There is still residual risk when you have used SGLT2 inhibitors, be it Cana, DAPA, or AMPA. You can see the residual risk getting reduced, but there is still some residual risk, which means we need something more. And with that in mind, we are definitely wanting to have more and more weapons in our armamentarium. So with this background, let us try and see what is the role played by mineralocorticoid receptor activation. Well, you see, we have always been targeting hemodynamics and metabolic profiles of our patients, especially diabetics, when we are looking to slow down the rate of progression of chronic kidney disease in these patients. What we have actually been oblivious of the fact is that inflammation and fibrosis play a big role. And now suddenly we have woken up to this reality, and we are now wanting to target this aspect as well. So what happens is that because of mineralocorticoid receptor overactivation, there is inflammation and fibrosis. So by giving them mineralocorticoid receptor antagonists, obviously you can mitigate the effects of this MR overactivation, which can be aldosterone driven, which can be cortisol driven, which can be decant independent, and they could be MR expression with high albumin urea. So whatever may be the cause, the effect of my mineralocorticoid receptor overactivation leads on to fibrosis and inflammation and fibrosis, resulting thereby in kidney damage, vascular damage, and heart damage. So with that in mind, let us see what the newer kid of the block, which is finerenone, which is a non-steroidal mineralocorticoid receptor antagonist, which is a bulky molecule and does not have the side effects typically associated with the conventional, the older MRAs, especially the androgenic side effects, the gynecomastia in males, which can be caused by them, or hyperkalemia. Now, it has been shown to cause an elevated hyperkalemia much less often as compared to the other drugs previously available to us. So, as you can see here, there are ways. I'm not saying they do not cause hyperkalemia, but yes, they definitely cause they have a much lower incidence of hyperkalemia. Well, there is a rule here, and the fives of finerenone treatment. You should initiate treatment only if your patient's potassium is less than 5, and you should stop the treatment if it is more than 5.5. You can initiate the treatment when the GFR is more than 25. Again, what you can expect is then the risk of end-stage kidney disease gets reduced by 1/5, and finerenone also has been shown to reduce the risk of hypertension, the hospitalization due to heart failure by 1/5. Now, these are the pillars, as you can see here. So these are the pillars which give us a lot of optimism as to how we can currently manage our patients. So MRAs have taken their legitimate place alongside RAS blockade and SGLT2 inhibitors. So suddenly, from the availability of nothing beyond RAS blockers, we have SGLT2 inhibitors and non-steroidal mineralocorticoid receptor antagonist, that is finerenone. Now, with that in mind, let us see if we have something more currently available to us. A lot of optimism. So we again have been part of flow trial as well, a very landmark trial. And again, the buzz is it has been stopped prematurely. Now, flow trial is was studying the effect of semaglutide in patients with diabetic kidney disease, and this is again based on our optimism and our faith in GLP-1 receptor agonists, as has been shown by other previously available GLP-1 receptor analogs, whereby they have had an impressive effect on the albuminuria and reduction of albuminuria. So although the conclusion here says that flow will evaluate the effect of semaglutide, as I have given you the insight, the trial has been prematurely stopped. We are in the process of having our end of the study visits of all our participants. And obviously, it means that it also has shown overwhelming superiority over the standard of care and plasma and placebo. So to summarize my talk for today, um, we have, as I said earlier, from nothing available to our patients, we have better understanding as to what an adequate control of blood pressure can mean to these patients, what kind of the good glycemic control, lifestyle modification can mean to these patients, achieved especially via RAS blockade, SGLT2 inhibition, and mineralocorticoid receptor antagonist, the newer non-steroidal one. And also, hopefully, we will see some great things coming out of a flow trial, reposing our faith in GLP-1 receptor agonists as well, as far as slowing down the rate of progression of chronic kidney disease is concerned. So this is the treatment algorithm for a given diabetic kidney disease patient. From out of nowhere, we see SGLT2 inhibitors reach and take the rightful place, whereby they have been shown to play a stellar role in the overall management of these patients. And I'm sure GLP-1 receptor agonists are not going to be far behind with more and more data. Now, I may actually conclude here, but just I'll rush you through these slides. The importance of metabolic acidosis. This has been shown to be one of the reasons which actually causes CKD progression. So if you can ameliorate metabolic acidosis in your patients via giving them alkali, by giving them sodium bicarbonate, it has been shown to have a very positive influence in the slowing down the rate of progression. This has been a meta-analysis. We must try to ensure, if possible, to keep your patient's bicarbonate upwards of 22, as close to 24 as possible. So oral alkali is all that it takes. The answer to that is available in your patient's kitchens as well. The sodium bicarbonate is there. So I will also want to touch upon a few things which are of uncertain benefit. So I would not want an indiscriminate use of these agents. Well, when it comes to keto analogs, there is a lot of debate. There is some data now favoring keto analogs. We were not favoring them for the lack of scientific data, but now there is some which says that maybe they have a role to play, but they should be taken as supplements rather than as a supplement to proteins, whereby they may prevent unnecessary protein breakdown when you have drastically reduced the protein intake. Whether and they have some pleiotropic effects and other aspects as well, be it phosphorus and parathyroid as well. So there are a few trials which speak in favor of keto analogs, but they are expensive. They add on to the pill burden, and they should not be promoted as if they are going to make a huge difference, and they are like going to reverse the process of chronic kidney disease. So I think they should be kept in their proper place, and rather than unnecessarily. And if they have to be used, they should be used properly, which means that the dose is about 9 to 12 tablets a day. And mind you, they're very expensive and they're big tablets. And probiotics, again, there was a lot of skepticism. There's only some recent data which they say that they may or may not have a role. Till the time we are having better data, not just the theoretical, which is why we are using them, I think we should refrain from a rampant use of these drugs. They are expensive again, and we should not give this idea to the patients as if they are more important than the drugs which actually have a bigger role to play, like the control of, like their antihypertensive, like their antidiabetics, etc. This is again some of the recent data which speaks in favor of probiotics, but then, as I said, the jury is still out. But one thing I would certainly want to caution is there has been a rampant use of N-acetylcysteine, and there are so many pharma companies promoting it. There is no scientific data supporting the role of N-acetylcysteine and taurine, and I think it'll be unfair to use it in all these patients. There has been no significant difference reported even in Indian this thing. So I will end here, and I'll be happy to take any questions which come my way. And I hope it has been of some utility to people who had joined us today. And thank you once again for your kind attention. Thank you.
Thank you so much, sir, for your wonderful presentation. We do have some questions from our audience if you like to take that up.
Yeah, please go ahead.
Yeah. So, sir, the first question is, what areas of research are currently underway in the field of CKD management, and how might these impact future treatment approaches?
Very nice, very interesting. Again, something very close to my heart. So, as you can see, we've been part of these landmark trials which have created a lot of awareness. And I'll say, starting from Credence with canagliflozin, and then we was part of DAPA CKD. AMPA kidney was never launched in India. They somehow avoided our country, but then I think they're probably Boehringer is coming out with many more trials addressing various aspects of chronic kidney disease. So, as I said earlier, on one hand, you are wanting to reduce the proteinuria in these patients. You want to preserve GFR in these patients. And at the same time, now with the newer thrust on the part played by inflammation and fibrosis, we have many new molecules which are currently being followed. We are going to be soon, as I said, GLP-1 receptor agonists are another area. Very impressive role played by mineralocorticoid receptor antagonist, that is finerenone, because it causes less of hyperkalemia and doesn't, it avoids typically those nagging androgenic side effects typically associated with the previously available MRAs. Now, there are drugs which are in the pipeline. There is to name a few. We are going to be a part of a drug called Zibo 1010, which was initially is from, I think, AstraZeneca. Initially, it was supposed to be an anti-cancer drug, but now they have realized that it probably has an impressive role to play in reducing albuminuria and slowing down the GFR decline. This is an endothelin receptor agonist. It's ETA specific, which has high specific, more than 1 lakh is to 1 in favor of ETA blockade, endothelin receptor A blockade, as compared to ETB. So that's going to be one impressive class of drug. Then we have an ongoing trials of finerenone to see whether it works in non-diabetics as well. We are part of FIND CKD trial. We're going to be soon part of a confidence trial as well, which has which is trying to tell us whether finerenone is better, or dapagliflozin is better, or the combination of the two is better, right? So then we while we are talking about mineralocorticoid receptor antagonists, we must also should remember that when the receptor is getting blocked with the help of MRA, what happens is the aldosterone levels will tend to accumulate because they are not going to be able to act on their receptors, and there is going to be a backlog, and there is going to be an increased in the concentration of aldosterone, which will now find ways to trouble the body, be it the heart or the kidneys. So why not we have something which targets aldosterone itself? So now we are talking about aldosterone synthetase inhibitors. Now there was a problem in till about a few years ago. There was another drug which addressed this problem, but this drug was not specific for aldosterone. As you know, aldosterone and the cortisol is right in its neighborhood. So there was not a drug which was specific for aldosterone. The earlier drugs also suppressed cortisol, and you can imagine what will happen to our patients if there was no cortisol. Now, with the availability of drugs like Baxdrostat, now that's going to be our next trial. So Baxdrostat is a direct aldosterone synthetase inhibitor, which is very specific for aldosterone and does not affect cortisol at all to that an extent, I would say. So lot of molecules on one hand, and this is one aspect of slowing down the rate of progression. And I'm limiting myself to CKD progression. I'm not talking about so many other exciting drugs which we have in the field of nephrology. Erythropoietin has paved way for oral HIF PHIs. That's one aspect. So there are many other drugs which are going to be soon available. There are drugs which are being targeted against glomerular diseases. We have drugs like complement direct alternate pathway inhibitors, iptacopan, which is going to be available for our patients with C3 nephropathy, IgA nephropathy. Talking about IgA nephropathy, we are certainly wanting an answer to this very common disease. IgA nephropathy, as you all know, is the commonest glomerular disease in our country as well. And unfortunately, we don't have any definite answer to it apart from traditionally used steroids, and everything else has been used but not found very efficacious. But now there is a flood of molecules being tried against IgA nephropathy. Now I'm talking about immunosuppressive, and I'm talking about which take care of the pathogenesis. But the interesting thing is, in both DAPA CKD and AMPA kidney, they were both tried in clinical situations of IgA nephropathy as well. And what we found was there was a great effect of these drugs. The hazard ratio was 0.29, which means 71% risk reduction if you had used dapagliflozin in those patients who were enrolled in DAPA CKD, because I told you 1/3 of the patient population in DAPA CKD were non-diabetics, and quite a sizable population of this were IgA nephropathy. I hope that answers, and there's a lot of optimism, as you can see, but what I have been saying over the last about an hour or so, that there is certainly good drugs available to our patients.
Thank you so much, sir, for answering our question. Next question is, sir, are there cost-effect strategies that can be implemented in managing CKD progression without compromising patient outcome?
Well, I think I would take it as a collective responsibility. You see, cost is certainly the deciding factor, and we can't go away from the fact that our country certainly needs to, and we all in our country need to be very mindful of the cost involved in these patients. But thankfully, once the patent gets over of a given drug, it becomes, I think, quite easily affordable, the way we have seen in many of these SGLT2 inhibitors, or for that matter, DPP4 inhibitors. When once the patent is off, obviously the drug becomes much cheaper and is relatively much easily affordable by bigger chunk of our patient population. So, but then you see, I would view it as a collective responsibility of all the individuals, of the government, all put together, of the pharma companies.
Thank you so much, sir. The last question from our audience is, what are the key parameters that should be monitored regularly to assess CKD progression?
I think In easy terms, albuminuria and GFR. And they're easy tools. I think it is again our responsibility to ensure that we monitor our patients' albuminuria, because that will give us an insight as to where we are heading. And of course, the GFR. Rather than talking about creatinine, we have creatinine value in front of us. All that we have to do is put it into a formula, the MDRD formula or CKD API formula, and figure out where does our patient stand. So this is our big responsibility, and of course, rather than just relying on routine urine examination, and I think that is not appropriate. You should always ask for, if 24-hour urinary protein urinary collection is perceived as cumbersome, I think you can have almost the similar values, similar information via a spot urinary protein creatinine ratio, or better still, spot urinary albumin creatinine ratio. I think let's not talk about cost at this stage. We have to get it done as in initial screening stages, just once in a year. I think 250, 300 rupees spent on albuminuria, or maybe 500 for that matter, in a few labs of albuminuria assessment and creatinine, which the cost could vary anywhere between, I would say, 50 rupees to 200 rupees. I think it's worth it once in a year. So, and yes, if your patient has fallen in the trap of chronic kidney disease, you will have to do it more frequently depending upon the GFR of a given patient. But these two, and once you put them on any therapy which can potentially raise their potassium levels, it's extremely important to monitor their potassium levels as well. Otherwise, it may actually be counterproductive. Right.
Thank you so much, sir, for answering all our questions. That's all from our audience. Before concluding today's session, sir, any last remark from you?
Well, I think I have certainly given my viewpoint, and I just hope that the audience liked the key points which I wanted really to share, and I hope it has added some value to their existent practice patterns. But yes, I'll end up by saying that chronic kidney disease is rampant in our country as well. Huge population is suffering from this disease. And while we have always struggled to find means to slow down the rate of progression, we have hope in the form of some molecules which I have talked about today. And it's our now collective responsibility to devise strategies how to best implement, how enroll them in our daily practice, so as to give maximum benefit to our patients. And I will conclude by conveying my thanks to IGCP for this wonderful opportunity once again. Thank you very much.
Thank you so much, sir, for joining us today.